Hello, my name is Dr. Patricia Coyle. I'm professor of neurology and director of the MS Comprehensive Care Center at Stony Brook University in Stony Brook, New York. We're going to be talking about an expert perspective on improving patient outcomes in relapsing MS from current oral disease-modifying therapies to emerging therapeutic options. We're going to have three distinct sections to this talk. The first is focused on optimal management of relapsing MS. How are DMTs used in clinical practice? Think of MS as a journey. People aren't born with MS, but they begin to develop it at puberty and post-puberty. And we know that virtually every patient that presents with MS has had the disease for a period of time. We're now realizing there's a prodromal phase that may stretch 5 to 10 years where the patient has not declared themselves with neurological issues as having MS, but there are other things going on. And then there's the frank clinical attack, the clinically isolated syndrome, a CNS inflammatory demyelinating attack, an optic neuritis, a transverse myelitis, an isolated brainstem syndrome that declares that they have relapsing MS, the major clinical phenotype of MS that accounts for 85 to 90% of patients. We also know that every relapsing MS individual is at risk of transitioning to progressive disease, secondary progressive MS, locked to midlife around ages 45 to 50. Now, in that prodromal period, and it really takes thousands of individuals to be studied to develop thousands that are due to come down with MS compared to matched controls. The studies of prodromal MS have indicated that there are things going on with regard to patients experiencing depression, anxiety, fatigue, pain, other medical issues, not clearly a neurological issue, for up to 5 to 10 years before they announce themselves as having MS. Statistically significantly greater medical issues going on in this prodromal period. And there are some biomarkers, radiologically isolated syndrome or RIS, that's not yet recognized as an MS phenotype. That refers to somebody who happens to get a brain MRI, and lo and behold, it's shockingly very abnormal and looks like MS. They have no history of MS. There's nothing to suggest it on exam. It turns out that RIS patient has about a 51% chance of developing MS within 10 years. And as they continue to be followed, that will likely go higher. That brain MRI is a biomarker for this silent phase of MS. In addition, increased neurofilament light protein has been documented during the silent phase. That's an axonal injury marker that can leach into blood. It has to come from the central nervous system. So we are seeing biomarkers of the pre-symptomatic MS stage. During MS, we're having an increasing lesion burden, macroscopic lesion burden occur within the central nervous system. That's bad because it means the MS patient is not going to age as well. We want to try to minimize that. And it's not just macroscopic damage, it's microscopic damage as well. Greater volume loss. We want to shut down that damage process, I think, as early as possible. And that's where treatment becomes key. We're so fortunate in having multiple disease-modifying therapies for MS. And increasingly, we can intervene to minimize damage to this most precious body organ, the central nervous system, so that the MS individual will age as well as possible. And that's why I think people want to start a disease-modifying therapy very, very quickly. We have multiple agents. We are so fortunate. I think MS is a poster child for success in the neurology field because of all the disease-modifying therapies. But they can become overwhelming. How can you present them in a meaningful way to patients? Well, I think it's very good to group them. And they really very naturally fall into three groups. The first are the needle injectables. These are our interferon betas, our glatiramer acetate, the original disease-modifying therapies. These are not immunosuppressants. They are immunomodulators. They are tried And true, they go back to the 1990s. Then we have the oral therapies, two families, the S1P receptor modulators, the parent compound fingolimod, and three second generation, siponimod, ozanimod, and ponesimod. The fumarates, another family, dihydroorotate dehydrogenase inhibitor, that's a mitochondrial enzyme that is the target of teriflunomide to decrease pyrimidine, and the purine analog cladribine. And then we have the monoclonals. We have the anti-CD20s, ocrelizumab, ofatumumab approved, rituximab off-label. It will never be approved for MS. The anti-CD52, alemtuzumab, and the anti-alpha-4 integrin natalizumab. So when we consider the management of MS, we start with diagnosis. We want to use the 2017 revised McDonald criteria. We want to analyze the patient. What is the tempo of their MS? How aggressive is the disease? And what is their prognostic profile? That will play into how we are going to treat them. How do we choose? Multiple factors, patient factors, disease factors, drug factors, all come into selecting in the individual patient what is the best disease-modifying therapy for that personalized one single patient. Right now, there's a big debate. Do we go with escalation, use a moderate efficacy DMT, very safe, or should we be using a high efficacy, even induction, long-lasting type agent? This is a big debate. No one would question going to high efficacy in somebody that had very active bad disease, but does every MS patient do better with that? We don't have that definitive data yet, and that question is being answered. With regard to monitoring, we need to monitor once we start a DMT. We need to follow the patient. We need to do a new baseline brain MRI 3 to 6 months on treatment, and then typically annually. And then managing. We need to know the side effects, the adverse effects, and what we need to follow as we start a new disease-modifying therapy. The needle injectables will have injection site reactions that we need to moderate. The monoclonals, we need to be aware of progressive multifocal leukoencephalopathy with natalizumab. We need to be aware of monitoring for immune-mediated diseases with alemtuzumab. With the anti-CD20s, we need to follow quantitative IgG levels as well as other factors. And the oral adverse events depend on the particular oral. Teriflunomide can increase blood pressure, can thin hair. The fumarates have gastrointestinal and flushing issues. The S1P receptor modulators may have infection in a minority of cases. So that will be a little bit different depending on that class. And cladribine produces a longstanding lymphopenia with perhaps an increase in infections. What about switching? Well, first of all, the patient has to be on the disease-modifying therapy long enough for it to be effective, and I think it takes at least 2.5 months. But once you've been on the agent within a year on your DMT, the American Academy of Neurology has told us if the patient has one or more clinical attacks or is developing disability worsening on the neurological exam or has 2 or more MRI lesions, that should trigger a switch discussion. So we have to be aware of that. We can't sit there as a patient is not doing well. And this was one switch study of relapsing MS that found a breakthrough activity, lack of efficacy was a key reason to switch in 58%, followed by safety or tolerability issues. But there are many others: inconvenience, compliance, mode of administration, injection fatigue, abnormal lab tests, pregnancy. So we need to be aware of that. So to summarize, we have multiple DMTs available for relapsing MS, which have demonstrated the ability to decrease the damage process to help patients to do better. Right now, there's an open debate about whether most MS patients should be started on a high efficacy, even induction agent, or a moderate efficacy, and we don't have the answers yet. But when we're choosing among our multiple options, very important in shared decision-making to speak to the patient and consider patient, drug, and MS disease factors. Our second talk is improving the quality of life of patients with relapsing MS, how to reduce the burden of symptoms with a disease-modifying therapy. We have many symptoms in MS, ranging from depression, anxiety, bladder, bowel, sexual dysfunction, cognitive issues, sensory, including pain, fatigue. These have a negative effect on activities of daily living and quality of life. We never want to ignore them. They are very, very important to recognize and treat and discuss with our patients. This is just one study that looked at patients that were starting ocrelizumab and what was their self-report of how happy they were with their treatment after a year on it. And what we're seeing here is evidence that patients improved in their satisfaction, their health-related quality of life evaluation improved significantly on their disease-modifying therapy. That's kind of an ideal circumstance. That's exactly what we want. And in the same group, they did a neuro-qual, quality of life score. That too improved after a year on this particular anti-CD20. So it clearly seems possible to improve self-reported quality of life in our patients, and we want them to like their treatment. We want them to feel that they're happier on it and doing better. Now, what about when you switched? This was a particular study from the Pacific Northwest MS Registry, and they propensity matched these two groups. They had MS individuals who started a needle injectable and stayed on it. They had another match group that started a needle injectable, but ran into various problems and switched to an oral agent. They then did their survey of patient-reported outcomes in those two groups. This was the PDDS score. That's a self-reported disability score. It was no different between those that continued on an injectable DMT and those that switched to an oral. And this is a quality of life evaluation. No different between the two groups. That's surprising. One might have thought you would have seen a difference in favor of the switch group. You did not, and it really indicates the importance of assaying quality of life and getting patient-reported outcomes from the actual subjects telling us how they feel they're doing on their treatment. That's a very important aspect. This is TerryPro. This was a very interesting phase 4 study of 1,000 patients started on teriflunomide. 600 of them were being switched from other disease-modifying therapies, about 75% the needle injectable, but also other orals and even natalizumab. And this was self-reported DMT satisfaction. It was positive in favor of those that switched, regardless of the reason for switching, and really covering virtually all classes. So here you were able to document on patient-reported outcomes improvement and happiness with making a switch. And I think it's important to survey the patient. Well, let's take one symptom, fatigue. We know this is a major symptom, and it can be debilitating. It can increase unemployment, interfere with the patient's ability to work and have a career. They're missing more time at work, and it can lead to physical limitations. It's a bad symptom of MS. It's a disabling symptom of MS. We need to be informed about it. There are different types of fatigue in MS. There's primary MS fatigue, but there's also fatigue due to depression, and fatigue due to disturbed sleep, and fatigue due to a drug side effect. And somebody might have nocturia at nighttime, disturbing their sleep, and that might be a key to their fatigue. So it's not as simple as it seems. You don't just survey and get reports about whether the MS individual is fatigued or not. You need to understand there may be multiple causes of that patient's fatigue, and you may be tackling them differently. So this is a very important thing to be knowledgeable about because you want to really be able to treat it effectively. And fatigue is a classic invisible symptom. You can't detect or quantify it by doing a neurological exam. You're basically depending on the patient's self-report, and there are various validated self-report measures like the fatigue severity scale, the modified fatigue impact scale, a visual analog scale, the fatigue symptom and impact questionnaire, for relapsing MS, we're depending on the patient reporting to us accurately how much fatigue they have, because it is invisible. There's no way to measure it right now. How do you treat it? A multiplicity of approaches, also depending on the cause of the fatigue. But you have non-pharmacologic therapies, like programmed rest periods, as simple as that. If you have heat-sensitive fatigue, which is peculiar to MS, then cooling techniques would be a valid way to approach things. Work accommodations, use of assistive devices, some very interesting novel techniques that are looking at stimulating the brain that might help, cognitive behavioral training. And then there are pharmacological drug therapies as well. Now, to be honest, we don't have very great data supporting drug treatment for fatigue. Nevertheless, on an individual basis, patients can have an excellent response. Things like amantadine, modafinil, armodafinil, amphetamine, methylphenidate have all been used. Again, not the strongest data, but individual patients may really benefit. So, can we expect that fatigue will lessen with an effective disease-modifying therapy? Well, quite frankly, we never start a disease-modifying therapy telling the patient, your symptom is going to get better. That's not what the goal of the disease-modifying therapy was. People were looking at clinical MS activity and MRI MS activity. That having been said, you would think that if you're on a disease-modifying therapy and it's controlling the abnormal immune process and the damage process to the CNS, that one might see improvements in certain symptoms. And this is just one example of both relapsing and progressive patients that were started on an anti-CD20 for a year, and they reported on their fatigue, and it improved after a year. It improved significantly, as you see. This is another study. This is the phase 3 trial that validated the second-generation S1P receptor ponesimod, where it went head-to-head against oral teriflunomide, so 2 oral agents. The amazing thing here was that they did as a secondary outcome a self-reported fatigue measure. And indeed, it was statistically significant in favor of ponesimod over teriflunomide, where over 2 years, you had worsening on the self-reported fatigue, and you did not see that at all in ponesimod, and that was statistically significant. Now, this really needs to be confirmed. There need to be other studies, of course, but I think it's very interesting, and it was very gutsy that they actually named this as a secondary outcome. So, really, to conclude on this quality of life section, quality of life is important. When you have multiple disease-modifying therapies and you start on a DMT, you might have perfect control of the damage process. But if the patient is miserable, that treatment is no good for them. We do not want people suffering when we have multiple disease-modifying therapy options. So this is dialoguing with the patient. This is asking the patient, how are you feeling? How are you doing? Are you tolerating this medication well, et cetera? It's important. It's an important component of the care of the MS individual and communicating and shared decision-making to know that they can tell us that their quality of life is good. We need to discuss their symptoms. We need to make sure we have therapeutic approaches. We may not be able to take all the symptoms away, but we should be able to make every symptom better. We need to know when we should switch a patient, for example, from a needle injectable to an oral DMT. For example, needle fatigue, even though the patient is doing very well, is a valid reason to switch an individual if it's going to improve their quality of life. In this third section, we're going to talk about how will practice change in the near future for patients with relapsing MS based on new clinical data. So, again, it's so exciting, the number of disease-modifying therapies that we have for relapsing MS going back to the early 1990s. But let's just look since 2010 at the explosion of new agents. 2010 really introduced the oral DMT to MS. So we started with fingolimod, the first approved oral disease-modifying therapy for relapsing forms of MS. Fingolimod was the first-in-class S1P receptor modulator. Multiple positive phase 3 trials, Freedoms 2, Transforms, where it was compared to IM interferon beta 1A. So that all occurred in the 2010 to 2014 period. Followed by teriflunomide, the next oral disease-modifying therapy, a once-a-day tablet targeting a critical mitochondrial enzyme for the pyrimidine pathway, a building block for DNA. Didn't touch the salvage pathway, so targeted were rapidly dividing cells, predominantly pathogenic lymphocytes, B and T cells in MS. This was not a lytic agent. It didn't kill the B cells. It froze them in the mitotic cycle so that they would not divide and multiply. And that turned out to be very helpful to control the MS damage process. And we had the phase 3 TEMSO and TOWER among the phase 3 trials producing the data that said this is an effective DMT. Then we had dimethyl fumarate, the third approved oral agent, define and confirm with the phase 3 trials here. Then we moved to 2015 to 2019, oral cladribine. Very interesting agent. This is the only oral induction agent. By induction, I mean you treat for a self-limited period of time and you have a long-lasting effect. With oral cladribine, you give it for 10 days in year 1, 10 days in year 2, and then you don't treat again in year 2 or year 3 or year 4. And this was supported by 2 phase 3 trials, including a clinically isolated syndrome trial. Then we also had diroximel fumarate in the fumarate class. This is exactly the same ingredients as in dimethyl fumarate. It's a prodrug, but it's packaged differently. And the 2 studies, Evolve 1, first of all, documented that this was an efficacious agent in controlling clinical and MRI damage parameters in relapsing MS. Evolve 2 compared it directly in a short trial with the parent compound dimethyl fumarate and was able to show significantly less gastrointestinal side effects. So this becomes a favorable agent among the fumarates to use. There's another fumarate that was approved here, monomethyl fumarate. This is not a prodrug. This is the active agent, and this added to the fumarate family as another option. And during this period in 2020, we now had the second generation S1P receptor modulator, siponimod. Fingolimod hits S1P receptor 1, 3, 4, and 5. Siponimod hits S1P receptor 1 and 5. The interesting thing about siponimod was that its phase 3 trial was in progressing secondary progressive MS against placebo, and they were able to show a significant effect on the primary outcome, confirmed disability progression at 3 months, at 12 weeks. That's a pretty tough nugget to crack in secondary progressive MS, yet they were able to do it, so more credit to them. And then ozanimod, another second generation S1P receptor, again hitting S1P receptors 1 and 5, more refined. 2 phase 3 trials in relapsing MS, Radiance and Sunbeam, where ozanimod orally daily went against IM interferon beta 1A and beat it on suppressing relapses, significantly less in the ozanimod arm versus the interferon beta arm in both trials. And then we had the third second generation S1P receptor in 2021, the most recently approved ponesimod. This is S1P receptor 1 specific. This was a head-to-head oral trial, patients randomized to ponesimod or teriflunomide, with the primary outcome suppression of relapses statistically significant in favor of ponesimod. Now, one of the things that we are really talking about is efficacy and high efficacy versus escalation therapy, et cetera. This recognizes there's different efficacy between the DMTs. When we talk about high efficacy, we're really talking about the monoclonals, and I would probably add cladribine there, maybe a little bit of a step down. All the other disease-modifying therapies are moderate efficacy. That's all the orals and the needle injectables. There's likely a difference among the orals with S1P receptor, perhaps being a little bit higher, at least than teriflunomide. But there are recognized differences. There's accumulating data that's showing us there may be a critical window of opportunity to maximize our treatment effect on long-term disability by treating early. And there's accumulating data. There are just two examples here where using a high efficacy early did better than using a moderate efficacy disease-modifying therapy early. Now, there are two ongoing trials that are randomized prospective trials where by randomization, patients are being put into an escalating arm or a high efficacy arm. The first is Treat MS, that has about 900 relapsing patients. The estimated completion is in 2024, and the other is Deliver MS, which again has about 900 patients, and that's finishing up in 2025. The point here is these are randomized trials. So we're going to see if being randomized to a high efficacy, you can show actually does better. In the one trial, the primary endpoint is time to sustained disability progression to the end. In the other, it's a brain volume loss. So these two trials are going to be very important to give us objective, evidence-based data on whether a high efficacy is preferred to escalation therapy or no. There may be patients that can do quite well with an escalation therapy. What's ongoing for relapsing MS? Ublituximab, I believe, will be the next approved disease-modifying therapy. It's completed 2 duplicate phase 3 trials where it went against teriflunomide, and it won an anti-CD20. This is given intravenously every 6 months. This is in front of the FDA currently, and I think we're going to hear by September that it's approved for relapsing forms of MS. So we'll now have 3 approved anti-CD20s. And then there are very exciting oral agents called Btk inhibitors that are in phase 3 trials for relapsing MS: tolebrutinib, evobrutinib, and fenebrutinib. These are agents that hit B cells and hit innate immune cells, macrophages, monocytes, and if they penetrate the CNS, and all 3 of these BTK agents do, they can hit microglia. So you may be able to influence the immune system, not just systemically, the way the monoclonals do, but also within the central nervous system. And so these trials are all recruiting now and ongoing, and people are very excited about what this might mean. So to summarize, the management of relapsing MS has become increasingly complex just because there are so many treatments. You really need to do your homework. You really need to be knowledgeable as you try to personalize and match with the individual what may be the best therapy for them. And you really want shared decision-making. You want an educated partner with the individual. The oral disease-modifying therapies have played a key component. They really were a convenient step beyond the needle injectables. They're very convenient to take at home. Really, safety has been extremely good. They're an important option. They're an important option for relapsing patients. We still look for novel treatments because we can always get better. We can always get better. And so we continue to mind that. We want that to continue. Our patients deserve it. And again, I think it's such an exciting time for MS, for relapsing MS. We're seeing the transformation of this disease in front of our eyes from a disease that was disabling and unpredictable and might have been a disastrous diagnosis to, I'm telling patients now, my expectation is you should be able to have a normal life. We just need to get you on the right treatment and follow you carefully, et cetera. So it's a very exciting time. Thank you.